Hello, I'm Jonathan Kay from the University of Massachusetts Medical School in Worcester, and I'm here at the end of day 3, November 8th of ACR Convergence 2020. I'm here with Richard Conway from Dublin, Ireland, Eric Dein from Baltimore, Maryland, Sheila Reyes from Manila in the Philippines, and David Liew from Australia. Which city are you from?
I'm in Melbourne, Australia. Yeah.
So here we've got an international group of people ranging from late at night to early tomorrow morning. And we've all attended the third day of the ACR Convergence, and we're all sitting in our home offices, having spent the day sitting at our computer monitors, seeing interesting presentations. So let's start off with Richard. Which presentation piqued your interest today?
So yeah, our regular panelist, Jeff Sparks, isn't here today, and I think he's gone for a lie down maybe because he's presented a huge number of abstracts today. So I thought I'd take advantage of his absence to talk about one of his. And it was a poster presented by first author Kazuki Yoshida. And it was on passive smoking across the lifespan and the association with rheumatoid arthritis. So they used the Nurses' Health Study to look at this, and very interesting results in that they found that parental smoking during childhood was associated with the later development of seropositive rheumatoid arthritis with a hazard ratio of 1.34. It's very interesting to speculate why that might be, why an exposure to smoking during childhood might be associated with rheumatoid arthritis developing many years later in the affected individual.
Very interesting. There was just an oral presentation this afternoon from the same Nurses' Health Study from the same group, which looked at healthy lifestyle. And they had 5 different elements of a healthy lifestyle: decreased smoking or non-smoking, minimal alcohol intake, exercise, healthy diet, and being not obese. And they found that there was essentially a dose response where the fewer adverse health practices you exhibited or the more healthy lifestyle you led, the lower the likelihood of developing rheumatoid arthritis, more for seropositive rheumatoid arthritis than for seronegative rheumatoid arthritis. But the exposure to passive smoke in childhood raises the question of the lung as the origination for rheumatoid arthritis. There was one of the plenary presentations today addressed that. Are any of you going to comment on that?
I can talk about it if you want.
Sure. Perfect.
So that was a study by Dr. Joshua, and they looked at 12 patients. So the individuals with seropositive arthralgia and then seropositive early rheumatoid arthritis untreated, and seronegative early rheumatoid arthritis also untreated. And they did bronchoscopies on these patients and bronchiolar lavage. And then they looked at what came out of that, and they found that the seropositive patients, either with arthralgia or with rheumatoid arthritis, had CD19 positive B cells there at higher levels than the seronegative patients. And they also found that these CD19 positive B cells were producing pathogenic ACPAs. So that's really interesting. It's again suggesting that the lung is a potential site of initiation and propagation of rheumatoid arthritis.
Absolutely. And the specificity of 2 or 3 of those ACPAs were for citrullenated fibrinogen, citrullenated vimentin, and citrullenated fibrillin. And the anti-citrullenated fibrillin antibodies were identified in one of Jeff Sparks's earlier presentations as a possible predictor of interstitial lung disease and rheumatoid arthritis. So the lung is one of the main themes of this meeting in terms of rheumatoid arthritis, and can't talk about the lung without talking about the heart, which pumps blood through the lungs. There have been some interesting cardiovascular abstracts at this meeting, especially today. Eric, I think you reviewed some of those.
Yeah, I would definitely, for anyone that's interested, point them to the poster sessions that were done this morning. in regards to cardiovascular outcomes in rheumatoid arthritis. And it really made me think about what the screening guidelines should be for patients with rheumatoid arthritis and what the rheumatologist's role is in that regard. I think we've started to recognize that lipid screening should be something that we need to take ownership on. And in particular, there's some new studies that I looked at today in regards to carotid ultrasounds, and makes you think about what our role or what a primary care or cardiologist role is in screening. So there were two studies that I thought did this really well. One out of Spain, it was 1179, and 1182 out of Mexico. And what they did, the Spanish study, they took a look at patients with rheumatoid arthritis, match against healthy adults, and they looked at patients for risk of carotid atherosclerosis. And so they excluded patients that were older, above 75, established cardiovascular disease or chronic kidney disease. They excluded patients with other inflammatory diseases, pregnancy, malignancy. And they took 200 patients with RA compared to a little over 100 healthy controls. And they found there was extremely quite a difference in bilateral carotid arteries, that there was a much thicker intima medial thickness, and the p-value there was very strongly significant. It correlated with the longer you have RA, the higher plaque burden that you have in your carotid arteries. You would expect, as they saw that age and blood pressure were also risk factors, but having RA, it didn't comment on the activity of RA, but at least the duration of RA was a very strong risk factor. And then that was supported as well by the study out of Mexico, where they looked at specifically postmenopausal women. And so these were patients between 40 and 75, postmenopausal. They had similar inclusions and exclusions, except they made sure that they had kind of similar menstrual histories. No one had irregular menses. And they showed the same thing, that right carotid atherosclerosis was more than double in the patients with a history of RA, so 19 versus 8%. So, I think the question here is what should our thresholds be to think about doing carotid screenings? Is this something that primary care should do, or which patient should we be sending to preventative cardiology, or when should we be thinking about placing these orders? Because I think we've expected primary care to take the lead for a lot of this, but I'm not sure that they're aware of this information. So I think this is going to be something that will be important for us to at least communicate and possibly drive this.
It's not just a matter of not being aware, but primary care physicians oftentimes have so many problems to deal with that they tend to refer rather than care for these problems. Rheumatologists now, with relatively brief times allotted for patient appointments, we have to deal with the joint disease, the monitoring of medications, medication toxicities, oftentimes explaining to the patient about a new medication if their disease requires a change in therapy, vaccination, withholding methotrexate for 2 weeks after the flu shot. So with all of those existing responsibilities, we should be incorporating cardiovascular health and prevention, but where is the time going to come from? Mm-hmm. I'm not saying to not do it. It's just we may need to see our patients more frequently. And then that plays into the workforce issue of are there enough rheumatologists to care for patients with rheumatologic diseases and take care of their general health problems? This is a major problem facing our major quandary facing our specialty. So, Sheila, you had seen some abstracts today that you were interested in.
Yeah, definitely. So I'd like to highlight two of abstracts that took my attention. So the first is number 1230 about curcumin. It's a study by the group of Dr. Lilian Rojas from Florida. So lately there has been interest in the use of curcumin because of its medicinal properties, including anti-inflammatory properties. And even in my practice, I get to see my patients taking curcumin tablets or even tea. We have it lots here. So this was a cross-sectional study that looked into the perceived efficacy of curcumin in rheumatoid arthritis and psoriatic arthritis patients. And patients were asked to answer a survey questionnaire on the source and the dosage of curcumin, the perceived efficacy, and the side effects. And the results show that patients had perceived improvement in pain, swelling, stiffness, and fatigue, showing that curcumin therapy might have a potential for symptom alleviation in these sets of patients. Not yet practice changing because there are still a lot of questions with regards to this study, and this was just descriptive. There were other questions like about the disease activity of these patients or the comorbidities. So I'm looking forward to further to looking into the further studies that could address these questions. And also, yeah.
So
And
it was a very interesting poster. One of
Yeah.
the limitations was that it was a questionnaire which assessed
Yeah.
patient response subjectively. So fatigue, pain, even subjective swelling, although there was a poster that was presented by Vivian, or an oral presentation by Vivian Bykirk about patient self-examination of the joints, which was similar to that of the physicians. But this poster assessed patient-reported outcomes, and it would be very interesting to see a prospective trial, perhaps a placebo-controlled trial of curcumin as an adjunct, perhaps, to existing therapies, to see whether these are borne out in an observer-validated trial. Yet another, I'm sorry, I interrupted you. So there was another presentation you were going to highlight.
Yeah, it's abstract 1465. So this was presented in the abstract sessions by the group of Dr. Sebastian Rodriguez Garcia from Spain. So they evaluated the impact of the combined vaccination scheme against Streptococcus pneumoniae and the incidence of related infections in patients with rheumatoid arthritis who were treated with biologic or targeted synthetic DMARDs. So this was a multi-center cohort study where the participant centers in Spain were surveyed about their vaccination policies. And the outcome was a composite of three points, which were the incidence of invasive pneumococcal disease, community-acquired pneumonia, and respiratory tract infections. And this study showed that the crude incidence rate of streptococcal-related infections and community-acquired pneumonia in the post-vaccination period were lower and was independent of patients' age, sex, comorbidity, and smoking status. So this gives us the importance of vaccinating our patients, especially since our set of patients are those at risk of developing infections, particularly respiratory infections. And I guess this sends out the message that vaccines work.
Absolutely. And it's important to keep track of which patients have been vaccinated in the context of our regular visits with these patients. The challenge is to remember to do it when you're busy monitoring their medications and their disease activity. Electronic medical records can be very helpful in this regard, just by keeping track with a flow sheet or possibly a prompt, although prompts sometimes are ignored if they become too frequent. So an important reminder about vaccination of our patients with rheumatic diseases. David, you're already in tomorrow. So, what was your highlight from yesterday?
Well, I'm already looking into the future and two things, two particular points from the poster floor today. They're maybe not necessarily abstracts people would immediately go to, but the first one was actually about biosimilars. It was actually some routine pharmacokinetic and immunogenicity data from biosimilars, but I think it raises an interesting point. Everyone concentrates on biosimilars being about savings, but it's also about manufacturers being more manufacturers for the same drug and driving innovation. So sometimes that means better support programs, better devices, pursuing new indications. For example, infliximab, the COVID study, infliximab is the Celltrion drug, but also means potentially going to better formulations. And so for infliximab, for the Celltrion product, they've been investigating for some time, moving from an IV to a subcut formulation, obviously incredibly useful as COVID starts to rear its head again. It's interesting because, so having this kind of immunogenicity data is really useful for that, because going from IV to subcut, the main concern really is about PK and about immunogenicity. Of course, immunogenicity is fine in this circumstance, but yeah, I think it really speaks to the role that biosimilars play. I don't think it's just about ticking the boxes at all.
This is the first biosimilar that is being marketed in a different dosage form than the reference product. Typically, the biosimilar regulations suggest that the biosimilar has to be given at the same dosing frequency and route of administration as the reference product. But here, Celltrion first got approval for CTP13 in the intravenous form, and then developed it in a subcutaneous form. Really a novel medication, a new biologic, but it's able to piggyback on the data for the intravenous biosimilar. So it's a very interesting development program.
It is. And it's interesting to see how different jurisdictions have dealt with that particular issue. It's the first time they've had to deal with it. But I mean, I guess it also stimulates, we've seen from the cancer space that it can stimulate that kind of innovation even in the originator manufacturer. So I think having more manufacturers does actually raise the competition and pushes things along.
Absolutely.
Yeah. The second one I just wanted to mention, and I think Richard probably will have some thoughts on it as well, is really about nintedanib. So definitely not a biosimilar. I think cost is always going to be a question about that. But it really comes down to whether there's potentially a role in interstitial lung disease across our diseases, thinking in particular about RA-ILD. Looking for an antifibrotic that might work in our patients. I know that we've thought a lot about the kind of things that might prevent RA-ILD and other rheumatic disease, interstitial lung diseases. But really trying to slow that progress when it happens, especially knowing that some patients do accelerate quite quickly, is still an outstanding issue. We've seen nintedanib in SSC-ILD, in IPF, and general fibrosing conditions, but really haven't seen the data for our conditions. Seen it piecemeal from time to time. There were two posters today. One of them looked particularly at data that I haven't seen before, looking at the number of patients who actually didn't progress with a greater than 10% absolute reduction in FVC. For me, that's a clinically meaningful endpoint. A lot of people say, well, the volumes that you save with an nintedanib aren't that great, but there was the absolute 20% difference between in the number of patients affected between going over FVC, an absolute FVC reduction of 10%. So for me, if you're treating 1 in 5 patients, that's potentially something to consider. The other thing to note was that it's clear that the UIP pattern patients are the ones who benefit the most as well. I guess that makes sense given that in some ways they resemble the IPF patients. But I think as we go along, we're going to get better and better at selecting the patients who this might be useful in, and potentially, by enriching that the patient population which we use it in, really I think we'll start to find a role for this kind of drug.
Absolutely. And we've seen at this meeting that the prevalence of rheumatoid arthritis, interstitial lung disease is greater than perhaps what we thought, that there are pathogenic antibodies in the lung, which may contribute not only to inflammation and joint disease, but also to fibrosis. These ACPAs in the lung in the study that was presented by Dr. Joshua stimulated fibroblast migration. So they could contribute to interstitial lung disease in that regard. They also were binding to activated neutrophils, again, could contribute to netosis and further generation of citrulline or antibodies to citrulline proteins. So the lung really is the alpha and the omega of rheumatoid arthritis, the inciting event and the end result. And we certainly need therapies like nintedanib and perhaps pirfenidone and others that can address the interstitial lung disease. So we've had a wonderful array of presentations that we saw today, cardiovascular disease, lung disease, nutritional supplements, healthy lifestyle, just to name a few that we've discussed. And I think everyone has had a very full third day of the ACR meeting, and we look forward to the final day of the meeting. It'll be a bit sad to not be in as close contact virtually with our colleagues, but I look forward to tomorrow and to having another panel discussion and to having more people join us on Room Now. So for further information about these and other presentations, please go to the Room Now website. And I'm Jonathan Kay for Richard Conway, Eric Dein, David Liew, and Sheila Reyes. Good night, or I guess good day from Australia. And we'll see you tomorrow.